How's it going, guys? It is 2:52 a.m. Sunday, May 15th here in Japan, and we have a high-yield rheumatology question for step 1 and 2. Obviously, many high-yield differential diagnoses here. I'll tell you the key points you need to know so you don't fuck up easy questions on your exam. So before we get started, please subscribe to my channel. I really appreciate it. Give the video a like. I really appreciate it. Find me on Instagram, Mehlman_medical, mehlman_medical. Link is down below. Find me on Telegram. The links to the Telegram group and channel are down below. Now let's start the clip. 78-year-old woman. She has diffuse aching of her shoulders and a bitemporal headache for the past 5 months. BMI is 35. Vitals are within normal limits. The DIPs of both hands show mild deformity. Range of motion is full. There is no edema or erythema of her joints. Neurologic examination is normal. ESR is elevated. Question wants to know the most likely diagnosis. So let's just walk through the answer choices here. We'll go backwards. Choice E, rheumatoid arthritis. Wrong fucking answer. You know instantaneously RA is wrong because the DIPs are involved. Okay, so in rheumatoid arthritis versus osteoarthritis, you need to know OA will affect the DIPs oftentimes, and RA does not affect the DIPs, okay? Only the PIPs and the MCPs. We could obviously do a 19-minute discussion of every little fucking detail about RA, OA, etc. Obviously, BMI is elevated, okay, in conjunction with DIPs. So she does have a background of OA, but this is not the main diagnosis here that we're interested in, okay? The point is RA, wrong fucking answer. Choice D, psoriatic arthritis, wrong answer. Okay, so there are no plaques classically, okay? Not that it's mandatory. 15% of patients with psoriasis will actually present with arthritis first. Patients a bit old to get a first flare of RA. Also, classically associated with the HLA B27 phenomena, PAIR, PAIR, psoriasis, ankylosing spondylitis, inflammatory bowel disease, reactive arthritis, okay? So obviously a lot we can chat about there, but psoriasis, wrong fucking answer. Now, this is where we get into the heart, the key details that you need to know, okay? Differentiating polymyalgia rheumatica from polymyositis. So both can present with pain and stiffness, not specific to either. Both can present with elevated ESR, okay? Both can even present with a low-grade fever during flares. This patient has normal vitals, okay? But you can get a low-grade fever in both. So how do we differentiate? I'll tell you. You will get weakness on physical exam, and or increased creatine kinase, CK, if the diagnosis is polymyositis, okay? If you don't have either of those, it's polymyalgia rheumatica. And in this case as well, temporal headache, okay, it's associated with temporal arteritis. It can be bilateral, not my fucking opinion. It's on the nbme exam, okay? So we look at the vignette here. There's no elevation in CK, and there's no weakness on physical exam, nothing about that. And it's really important that you underline in your mind physical exam, okay? Because the patient can walk in and say, you know, I've had weakness, pain, and stiffness over the past 6 months. Physical exam shows 5 out of 5 strength of the upper and lower extremities. That's not weakness, okay? So it must be fucking weakness on physical exam and or an elevation in CK. That's polymyositis. Polymyalgia rheumatica, you're not going to have either of those. And obviously associated with temporal arteritis, you're going to give steroids to prevent blindness and then do biopsy, okay? And polymyositis, you're going to have a T-cell infiltration in the muscle, and you will have anti-Jo1 antibodies. A lot we could talk about, right? But as I told you, those key differences right there, very, very high yield. Fibromyalgia is a psych condition. Generally a younger patient, woman, 20s to 40s, who's had stresses, and she will have symmetric tender points on her muscles. You treat this with SSRIs. They will write it sometimes in USMLE as antidepressant medication. Okay, student gets confused. They're like, but she doesn't have depression. You're right, she doesn't have depression, but SSRI is still how you treat fibromyalgia. Okay, so high yield diagnoses here. I told you the 2 ways to distinguish polymyositis from polymyalgia rheumatica. In this case, we've got polymyalgia rheumatica. You know the deal. I'm going to continue to make more content. If you like my stuff, subscribe to my channel. I appreciate your time. That's it.